Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, listeners, and welcome back to another episode of the Radiology Cardiothoracic Imaging podcast. I am your host, Praveen Ranganath. On today's episode, we will investigate an exciting new publication in the journal titled Coronary Artery Calcium Scoring, New Insights into Clinical Interpretation, Lessons from the CAC Consortium. This review comes to us from our colleagues at Johns Hopkins University. The first author is Dr. Siegfried Edelhofer, and the senior authors are Dr. Omar Dize and Dr. Michael Blaha. Many of our listeners will be familiar with the robust data supporting the prognostic power of calcium scoring in predicting adverse events. Multiple large registries, including the well-known MESA registry, have helped validate the use of calcium scoring in appropriately selected patients. Our featured publication reviews the results from a more recent cohort study known as the CAC Consortium. The CAC Consortium was a very large, multi-center retrospective study focused on coronary calcium and long-term cause-specific mortality. This robust review outlines the results of CAC Consortium studies published between 2016 and 2020. Some highlights from this review include the following: the impact of calcium scoring irrespective of patient demographics, identifying high-risk patient groups with scores greater than 1,000, and de-risking low-risk groups with scores of 0. To help unpack this review, I spoke with our featured publication's senior authors, Dr. Omar Dize and Dr. Michael Blaha. Let's jump into that conversation now. Hello and welcome back, listeners. I am privileged to be joined by two of the authors of this episode's featured paper, Dr. Omar Dize and Dr. Michael Blaha from Johns Hopkins University. Thank you so much for joining me on the podcast, guys.
Yeah, our pleasure being here.
Thank you so much.
Of course. First off, tell us a little bit about yourselves. Where are y'all practicing right now, and how did y'all get involved in coronary imaging and preventive cardiology? Omar, why don't you go first?
My name is Omar Dize, and I work with Dr. Michael Blaha at the Coronary Center. My background is I had my training in Germany at Charité in Berlin. And after finishing medical school and radiology training, I came over and joined Dr. Michael Blaha's lab. And yeah.
Excellent. And Dr. Blaha?
Yeah, so I've had an interest in preventive cardiology for a really long time. So I, as opposed to Omar, who kind of comes from an imaging background, I started off not in an imaging background. In medical school, I worked on insulin-resistant mice, thought a lot about the metabolic syndrome, which translated quickly over into cardiology, in particular preventative cardiology. So as I entered my residency and fellowship, I knew I wanted to be on the prevention side. But then I grew to appreciate the area where imaging and prevention comes together. And risk stratification and kind of appropriately titrating the intensity of our preventive therapies as a kind of novel and important clinical area. Really during, I guess, my fellowship is where I really started that. And then I, got level 3 training in CT during my fellowship, and ever since have been an imager too. So I came from a background of kind of metabolic syndrome, and then imaging, and Omar from a kind of an imaging and is learning cardiology. And we met, I was an attending on the clinical cardiology service, and Omar rotated on as a sub-intern, I think it was, as a visiting sub-intern. And then we formed a research collaboration with obvious overlap of our interests.
Perfect. That's excellent. And that dovetails very nicely into the topic of your review, which is the Coronary Artery Calcium Consortium, or the CAC Consortium. a lot of us are familiar with other databases and data sets out there, particularly the MESA database. Can you help us understand how the CAC consortium compares to other registries that may be out there on atherosclerosis, for example, MESA?
Yeah, I can give some background on that because I have worked in MESA for well over a decade now. So, of course, the NHLBI, the National Heart, Lung, and Blood Institute, has been a very strong proponent of prospective cohorts from a long time now, starting with the Framingham Heart Study decades and decades ago, followed by studies like the Jackson Heart Study, the Atherosclerosis Risk and Community Study, and then MESA. And really the novel aspect of MESA was that it was a study of subclinical disease as opposed to just overt cardiovascular disease. So MESA really taught us a lot about subclinical coronary atherosclerosis, subclinical left ventricular dysfunction, diastolic dysfunction, and SCAR have been some of its major contributions. And MESA has been very influential, of course, in the guidelines and telling us how important it is, for example, testing subclinical atherosclerosis and predicting future risk. Now, it takes a lot of money and a lot of time to do one of these prospective cohorts, of course. It took years in the planning, and it's now taken 20 years to accumulate the data for MESA, which launched in the year 2000. So while that's been a wonderfully fruitful investment from the NHLBI, of course, every question can't require a prospective cohort or else we would never get the research done. So the Calcium Consortium is different in that we're leveraging existing clinical data, especially now that we all have medical records so and so forth. It's easier to synthesize and harmonize data across clinical centers. Of course, because we'll talk about, I'm sure, soon, is the calcium score uses a common scanning protocol across all centers. That makes the data very easy to put together. So what we did here was we put together the clinical data from the early adopters of calcium scoring dating back into the 90s, even before MESA started, and able to then link that data to outcomes and then have basically just as long, if not longer, follow-up than MESA that's largely replicated its findings, but with a fraction of the cost. So it's an important message in kind of a digital clinical epidemiology and important for imaging. I think probably both calcium scoring and other tests, to show that we can do a lot of the work we have done in the past with prospective cohorts with the electronic medical record-based digital cohorts. So that's kind of where MESA and the Calcium Consortium overlap. Omar, maybe you could comment sort of on, what are the strengths and weaknesses a little bit between, let's say, a study like MESA and the Calcium Consortium, because really they're very different too.
Thank you. Obviously, so if you think about a prospective study, baseline information is collected from all subjects in the same way, using exactly the same questions and data collection methods for all subjects. So the investigators design the questions and data collection procedures carefully in order to obtain accurate information about exposure before disease develops in any of the subjects. So after baseline information is collected, subjects in the prospective cohort study are then followed longitudinally over a period of time, usually for years, to determine if and when they become a disease and whether their exposure status changes. So in contrast, if we think about the retrospective study, these studies are conceived after some people have already developed their outcome of interest. So the investigator, they jump back in time to identify actually a cohort of individuals at a point in time before they have developed the outcomes of interest.
Excellent. Thank you guys for that review, because a lot of our listeners may not be familiar with the differences between retrospective and prospective registries that are available, particularly when it comes to CAC Consortium. Many of our listeners are probably familiar with interpreting the scans, utilizing the information from coronary calcium scans, or even both. I'm sure that they're generally familiar with the well-established value of these scans and risk stratification. For that reason, rather than focus on what we already know, I'd like to focus on what we have learned from the CAC Consortium. Omar, can you help break down some of the demographic specific impacts of coronary calcium that you described in your review?
Yeah, let's start actually with the demographic differences between men and women, for example. Compared with men, women experience fewer CVD events. So however, the fatality rate remains critical and makes CVD a major public health issue in women. So fundamental cause explanation about the pathophysiology and underlying etiology remains unanswered. So the most frequent cause of coronary thrombosis is plaque rupture, and hence pathobiologic sex differences have been hypothesized, such as difference in size of coronary arteries between men and women. So if you look at the CAC Consortium, Women and men had average PCE risk scores of 5.8% and 9.8%. So within CAC subgroups, women had fewer calcified lesions and vessels and greater lesion size and higher plaque density when compared with men. For women and men without CAC, long-term CV mortality was similar, whereas detectable CAC was associated with 1.3 higher hazard for CV death among women when compared with men. So cardiovascular mortality was higher among women with more extensive, numerous, or larger CAC lesions. So the relative hazard for cardiovascular disease mortality for women and men was 8.2 versus 5.1 for multivessel CAC and 8.6 versus 5.9 for CAC lesions. Additional explorations revealed that women with larger size and more numerous CAC lesions had 2.2-fold higher CVD mortality as compared to men. So, moreover, CAC density was not predictive of CV mortality in women, but was for men when controlling for CAC volume and cardiac risk factors.
Interesting. So there are very clear sex differences that are demonstrated not only based on CAC presence, but also based on morphology, density, etc. Are there any other demographic differences for which these similar metrics are able to pick who is at higher risk than others? For example, pre-existing conditions such as hypertension, smoking, etc.?
Yeah, interestingly, we look, for example, also into race. So in the CAC consortium, for example, we have 38,277 white, 1,621 Asians, 977 blacks, and 1,349 Hispanics, with a mean age of 55 years, and 35% of them were women. And they were all followed up over a median of 11.7 years. Increased CAC was associated with higher total and CVD mortality risk in all race ethnicity groups, including Asians. However, the risk gradient with increasing CAC was more pronounced in blacks and Hispanics. So in fine and gray subdistribution hazard models adjusted for traditional cardiovascular risk factors, and blacks and Hispanics showed greater risk for CVD mortality when compared with whites, while Asians had risk similar to whites. These race ethnicity differences persisted when CAC was 0.
Interesting. And with regards to a CAC of 0, I know that in the review and also outside of this review and just general thinking about coronary calcium, there's multiple subgroups of coronary calcium beyond race, beyond gender that we try to think of and try to lump patients into when determining risk. Some of those groups that you mentioned in your review are the CAC greater than 1,000, and as you just mentioned, the CAC equal to 0, or what we on social media would say is the power of 0. Can you go into the implication of each of the CAC values for these subgroups when it comes to potential risk stratification and management strategies?
Yes, thank you. So while CAC scores of over 300 or 400 have been traditionally recognized as the highest risk classification of CAC, there are, however, a unique group of individuals with CAC scores over 1,000, many of whom are asymptomatic at the time of scanning. So arguments have been made that high CAC values are heavily influenced by CAC density, which might be associated with more favorable, as denser CAC are more indicative of stable plaques, which are less prone to rupture. So individuals with very high CAC scores above 1,000 have, however, been found to have higher CAC area and more extracoronary artery calcium, and to be at much higher risk of CVD, CHD, cancer, and all-cause mortality than those with CAC scores of 400 to 999. These patients have been found to have as much risk as those in secondary prevention who have had prior myocardial infarction, suggesting that even more aggressive management of modifiable risk factors might be warranted in this subgroup of individuals. So the overall recommendation would be CAC scores above 1,000 should be considered a distinct, very high risk group and should be identified as such on score reports.
Interesting. So despite the general thinking that as plaques are quote unquote treated or evolve, their density increases, this subgroup with CAC scores greater than 1,000 actually portend a much higher risk. Is that correct?
Yes.
Okay. And how about for our patients that do not have any identifiable coronary calcium on these scans? Is there still a potential risk of these patients developing cardiovascular events? And how does that compare to those that have a CAC of 1 or greater? Yeah.
Sure. Yeah, glad to comment on this important topic. So Omar covered very well the very high calcium score group, which can have risk that approaches that of secondary prevention, which is important in our clinical decision making. But really important when you talk about imaging is to also think about people who lack disease, right? I think this is something that's in common across almost all imaging phenotypes, is when you don't have something, you end up being at very low risk of that outcome. And this is particularly true when you look at atherosclerosis phenotypes. Since atherosclerosis is quite common, when you see no atherosclerosis, it really identifies a group that's unique and uniquely low risk. So the calcium score of 0 has emerged as probably the strongest negative risk marker of developing cardiovascular disease. In other words, if you use the pooled cohort equations, which is our risk tools that based on traditional risk factors, everyone's going to have risk as they age. They accrue risk based on their age and their gender in particular. And it's very hard to become low risk as you become an older individual. So it's very important to identify those tools that actually tell us who is not at high risk, who would have otherwise been considered high risk just based on their age alone. So in this case, looking directly at atherosclerosis in the coronaries and finding none, the calcium score of 0, can de-risk or downwardly risk stratify patients as strongly as any other test, and really opens up a new world of personalization in primary prevention. So just like when someone comes to the emergency room and has nothing on their CT angiogram and you can send them out the door more quickly, if someone comes to you in primary prevention concerned about their risk and you get a calcium score in at 0, you can be much more reassured about their risk profile and perhaps be less aggressive than you would have otherwise. So the calcium score, importantly, not just identifies high-risk patients, but can also identify low-risk patients too, a true risk stratification tool, as opposed to things that we use in cardiology like blood biomarkers, for example, where we really only find high-risk patients. You can't typically reassure a patient just because a single blood test is low. So the calcium score of 0 is an extremely powerful tool for identifying usually something in the order of about 2% risk over the next 10 years of developing a cardiovascular event, which is below the threshold of aggressive treatment for any of our present pharmacotherapies, where we can focus on lifestyle more. But I think this makes sense to all the imaging audience out there, right? You open up a study and there's no detectable plaque. If there's no detectable plaque, it's hard to imagine that atherosclerosis modifying therapies are going to make a big difference. Certainly a big difference, at least over the short term. So this is what the Calcium Consortium has confirmed from prior studies, is that the very large amount of people with calcium scores of 0 can enter into a very low risk group, and we can think about them differently. And guidelines are starting to adopt this, as you said, power of 0 concept. People have doubted it in the past, but it's been confirmed from many studies. And for example, in the Calcium Consortium, we've shown also the interaction of the calcium score of 0 with the current guidelines, showing that many patients who would otherwise qualify for preventive pharmacotherapy might actually have a calcium score of 0 and be much less likely to benefit. So I think that's the bookends of the story about calcium score on the very high end and the very low end. And I think we're appreciating so much more detail within the calcium score than we once did, where we said, is your score high or low? Now we're saying, well, is it nothing, a little bit high, very high, or extremely high in the case of the scores of 1,000, where we might think of these patients differently. So now we just need to get our insurance companies and payers and guideline writers to appreciate really the array of risk information that we get from this test.
Excellent points. And with regards to helping publicize the information that's available from this robust consortium and all the publications that have come from it, does the consortium and the results from it jive with the evidence that has informed the previous ACC and AHA guidelines on cholesterol?
Yeah, so this is a good point. So Omar's written about this recently, and I've been thinking about this for a very long time. Of course, the 2013 guidelines, the American College of Cardiology and the American Heart Association, gave only a tepid recommendation for calcium scoring. They listed calcium scoring one of many tests that you could consider for further risk stratifying an individual. And many of us in the imaging community thought that was a missed opportunity to differentiate the calcium score from other tests. For example, the calcium score was lumped in with other blood biomarkers, for example, or whether someone has a family history of heart disease or not. But of course, it's very different. If someone says they have a family history but have no plaque, it's very different than saying, for example, someone doesn't have a family history but has a high plaque. It's hard to consider those similar phenotypes. But the data from MESA and the data from the Calcium Consortium to some degree influenced the 2018 guidelines, which clearly differentiated the calcium score as the preferred test for risk stratification, and kind of putting back on the priority list a little bit some of these other tests, for example, blood tests for inflammation like C-reactive protein. So these kind of studies have been extremely important in influencing the guidelines, but I still think that once you have the guidelines, it's hard necessarily to get everyone to uptake them right away. I think this is where the consortium has played a very big role in confirming much of what's in fact, pretty much all of what's in the guidelines. And that includes that the calcium score has the most value in borderline to intermediate risk patients. Calcium score can be used in select younger patients also to identify risk. The calcium score of 0 is highly reassuring. Very high calcium scores have risk that approaches that of secondary prevention. These are some of the messages that are embedded in the guidelines that have been confirmed by the Calcium Consortium. So I think that many people who thought that maybe the guidelines give too strong of a support for calcium scoring have come to recognize that these confirmatory studies are supporting everything that's said in the guidelines. For example, that the calcium score adds significantly to the pooled cohort equations, the preferred risk tool in the guidelines, and that in, for example, intermediate risk patients who've got scores of 0, their risk is actually below that of what we consider appropriate to treat. And Omar, I know you wrote a review, I guess that was a year or two ago, kind of thinking about this and where the 2018 guidelines took us. And I guess and future guidelines are coming soon that will I think expand upon the role of calcium scores. But any particular aspect of the consortium that you think really confirmed what we saw in the 2018 guidelines?
I have not much to add on that point, but I think what is also interesting, if you think beyond actually what is in the guidelines and what we are working on, is that elevated CAC scores have been also associated with an increased risk of other non-cardiovascular diseases, including cancer, chronic kidney disease, and chronic obstructive pulmonary disease, for example. And I'm pretty sure we will go to this as the next point here in your list also, right?
Yeah, I'm glad you mentioned that because I found it very interesting, and many of our listeners probably know about the significant risks of all-cause and cardiovascular mortality in patients that have more coronary calcium. But the interesting thing is with regards to cancer mortality and other cardiopulmonary diseases and their association with coronary calcium. Can you help dive into that just a bit more, help explain that for us?
Yeah, sure. So these comorbidities actually that you mentioned right now raise the issue of competing risk of mortality in those with elevated CAC and should be considered when analyzing CAC as predictor of mortality. So there are tools currently being developed to further translate the CAC score into a likelihood estimator for mortality from CVD versus cancer, which could and will inform and potentially impact clinical management decisions. So in the United States, CVD and cancer remain the leading cause of death. So by assessing competing long-term risk of CVD versus cancer mortality, over a median follow-up of 12.4 years, our dear colleague Seamus Welton presented 2 key lessons based on the CAC consortium. Firstly, cancer was the leading cause of death when CAC was 0 and then accounted for 50% of deaths in this group. Secondly, patients with a CAC score above 300 had a risk of CVD mortality almost 4-fold higher than patients with a CAC score of 0, and a risk of cancer mortality 1.3-fold higher. The leading cause of death in patients with CAC score of 0 is cancer, irrespective of age or sex. CHD and CVD mortality was low in this patient group at 0.32 and 0.3 and 0.1 per 1,000 person years for women and men respectively. So CVD overtook cancer as the leading cause of death at CAC scores above 400. So among this group with CAC score above 400, women showed higher rates for cancer and CVD compared with men. So if you look at women, we saw actually a U-shaped relationship for CVD versus cancer mortality, whereas this relationship was found to be exponential for men. These findings highly suggest a synergistic use of CAC for risk prediction and subsequent prevention strategies of both CVD and cancer.
Very interesting. Dr. Blaha, is there anything you'd like to add to that relationship between cardiovascular morbidity and mortality and cancer mortality as it relates to the CAC consortium and coronary calcium in general?
Yeah, I think it speaks to our enhanced understanding of calcium scores, not just a tool to mark burden of atherosclerosis, but actually to mark so what we refer to as biologic age or accumulated kind of risk throughout the whole body. So we know that, for example, you can use the age on your birth certificate to roughly estimate your risk of a variety of conditions, including of dying, right? But we all know as clinicians that there's some, for example, 60-year-olds who are extremely high risk and some 60-year-olds who appear to be aging extremely favorably, right? So just using someone's age alone is just a poor indicator of their health status. It works at a population level, but not sufficiently at an individual level, right? So we think the calcium score, by identifying someone who's at high risk, not of just cardiovascular disease, but also cancer and other chronic illnesses, is really a good marker of sort of the so-called biologic age of the patient. Because we know that people experience risk differently. I mean, even someone with the same risk factors can develop disease at a very different rate, and the calcium score helps quantify that. So not only helps identify, I think, your kind of risk factor load over your lifetime, but also your vulnerability to those risk factors and the likelihood that you've developed tissue injury. And if you're developing tissue injury from risk factors, you're not at a high risk of just atherosclerosis. You're actually at high risk of a variety of conditions. In this case, including cancer. It's identifying someone who's at risk for developing, like I said, tissue injury from risk factors. So this opens up a whole new world of thinking about calcium scores, because maybe the calcium scores, as Omar mentioned, can tell us over the long term what you're more likely to die of. And if you're aware of what you're more likely to die of, you're more aware of where you should be putting your preventative resources. So if we can identify a group of patients who, let's say, are 60 years old, who've got a score of 0, and we can say it's much less likely that your fatal outcome would be cardiovascular, it's more likely to be something else. That might shift the way we use our preventative resources. For example, it might be much less likely that aggressive anti-atherosclerotic therapy is going to extend your life, right? That's a different way of expressing the power of 0, right? If you've got a 0 calcium score at a later age, we can't make you live longer with preventative atherosclerotic therapy, but maybe we need to focus our attention on other preventive strategies. Where on the other hand, if you identify someone who have a high calcium score at a young age, and we could say you're maybe 3-fold more likely to die of cardiovascular disease than cancer, it makes all the sense in the world to put that person on very aggressive preventative therapies, because we're much more likely to extend their life. So what we think it does is the calcium scores can tell you kind of the mix of diseases that you're at risk for, but also risk stratify patients who are at higher risk for cancer and for other bad outcomes. So I think this is just the next step in the evolution of thinking of the calcium score as just a tool to measure atherosclerotic burden, rather now to measure a tool that measures increased risk in general. And maybe Omar can quickly comment on kind of upcoming work he's doing on patients who have high calcium scores and their risk, in this case, of future development of lung cancer, which has relevance, I think, to the audience who does lung cancer screening CTs.
Yeah, Omar, please. Can you talk about what work you've done previously, how it relates to coronary calcium, as well as any sort of cancer mortality? It sounds like lung cancer in particular is your area of expertise.
Yes. So we have 2 studies actually ongoing, specifically focusing on cancer subtypes. So cardiovascular disease and cancer are the 2 leading causes of death in smokers. And coronary artery calcium scores are associated with CVD and overall cancer mortality, as we published previously. In this ongoing new study, actually, we examined the implication of CAC scores for lung cancer and overall cancer mortality risk prediction for patients in the coronary artery calcium consortium. So what we did was we included 55,943 patients aged 44 to 84 years without known heart disease from the CAC consortium. And the mean age of lung cancer deaths was in that study 63.9 years, and 33% of them were women and 91% were white. Overall, lung cancer mortality increased with CAC scores with rates per 1,000 person years of 0.2 for CAC score of 0 and 0.8 for CAC score over 400. Compared with CAC 0, hazards for those with CAC over 400 were increased for lung cancer mortality, which was driven by women, but not significantly increased for men. Risks were higher in those with positive smoking history and predominantly in women. Results for overall cancer mortality showed consistently higher, highest hazards for those with CAC over 400 when compared to CAC 0. So CAC scores were associated with increased risk for lung cancer mortality. However, this was strongest for current and former smokers, especially in women. So our exploratory data pinpoint a potential synergistic use again for CAC scanning, for CVD assessment, and in conjunction, future clinical variables for identification of lung cancer screening candidates.
Fascinating. Thank you both. This is a really interesting discussion as to what coronary calcium likely will become over the next few years. If you could briefly comment on any additional upcoming steps for the CAC consortium that y'all are seeing.
I'll make a couple comments and I'll pass it over to Omar. There's still an incredible amount of work to be done in the field of coronary calcium scoring. It's interesting, a decade ago, I remember 15 years maybe ago, I remember a colleague of mine saying, well, I don't know, there's much to do in the calcium scoring field anymore. We've already shown that it predicts risk. But, that's such an early part of the story to say that something predicts risk. Well, we've gone on to say, how much does it predict risk? What groups does it predict risk most in? Can you incorporate it into guidelines and in whom? Can it drive therapy of aspirin, statins, or other things? And now we're getting to so many other aspects of calcium scoring. And one of the ones I wanted to hit on quickly was also the implications of at least qualitative calcium scoring on all non-gated chest CTs. Because we know now that if you get a dedicated calcium score, you can predict risk quite well. But what about the 80 million CTs of the chest that are done every year, many of which are non-gated and are not done for the purposes of looking for risk in the heart? The lung cancer screening CT would be one example, but there's many others, of course, from a variety of maybe people getting CT scans for COVID. There's embedded information in there. The reason you order the test, but is important nonetheless. So the Calcium Consortium has also hinted and confirmed ideas from the Society of Cardiovascular CT that at least qualitatively assessing calcium burden on a non-gated chest CT can predict risk extremely well, and including if you include not just the burden of calcification, but the number of coronary vessels that are involved. You can do a very rapid assessment of someone's risk, even without doing a dedicated calcium score. And the Calcium Consortium looked at this and confirmed what the SCCT proposed in the so-called CAC data and reporting system, the so-called CAC DRS scoring system, that a radiologist or a cardiologist or anyone opening up a chest CT can say, well, this patient has severe calcium and it's in all their coronary vessels. This is a high-risk patient. I don't even necessarily need a formal calcium score in this setting because the data is already there. Or very commonly, a patient gets referred to my clinic and they haven't had a calcium score before. They don't know their risk, but I look and they've had a chest CT 3 or 4 years ago, and I open it up and look at it. I think once upon a time, we didn't do that. We didn't say, open up those non-gated chest CTs and look at that for coronary calcium, but now we should. It's guideline endorsed to do so. And in the Calcium Consortium, confirmed to actually predict risk almost as good as a formal calcium score. So this is extremely important. I think the concepts that were brought up there is that it's not just the how much calcium that matters, but also the distribution of that calcium. The more diffusely it's distributed in your coronary tree, hints at how more diffuse atherosclerosis you have. So I think people should be looking at the scans not only for how much calcium, but how diffuse it is to get a sense. This is one aspect that we're kind of continuing to develop in the Calcium Consortium, which I think takes you from those of us that are still high adopters of the calcium score that use it all the time, but takes it to all the people who don't necessarily order a lot of calcium scores, but maybe see a lot of patients who've had chest CTs before. Oncologists have been referring patients to me quite a bit recently as they get these score reports back now, or they get their chest CTs back that refer to advanced calcification and they want some help. So I think that's a future area of interest that's going to take calcium scoring even broader than it is now. And Omar, you've thought a lot about a kind of CAC DRS and CAC on non-gated images. I think for this audience here, the radiocardiothoracic imaging audience is of particular importance.
Absolutely. Thank you, Mike. So, as Mike mentioned, for me, especially as a radiologist, this is very impactful. So we have over 7 million CT scans actually are done in the United States annually, with projected doubling of that number if thoracic screening with annual low-dose chest CT is done in all patients at risk for lung cancer per the 2014 United States Preventive Service Task Force recommendation. So CAC can be assessed visually on almost any chest CT scan, but has been mostly ignored until recently, to be honest. As lung cancer and CHD share similar risk factors, the 2016 SCCT-STR guidelines assigned a Class 1 recommendation for routine qualitative CAC assessment on non-gated thoracic scans, regardless of the indication for the scan. CAC scores on non-gated thoracic scans can be estimated qualitatively on visual assessment as present and not present, or as mild, moderate, or severe. They can also be assessed quantitatively for each of the 4 main coronary arteries using ordinal scales of 0 for no CAC, 1 mild, 2 would be moderate, and 3 would be severe. One previously proposed score is calculated as the sum of the scores for each of the coronary arteries and can be categorized into 3 categories of severity. Again, 1, 1 to 3, 4 to 12. So, as Mike mentioned, despite the many established benefits of the CAC score, more work needs to be done to optimize and standardize its application in clinical medicine. One approach is to merge traditional and qualitative CAC scoring to yield a score that classifies individuals accurately regardless of the method of CAC assessment used. This is actually easily achievable, as evidence suggests that experienced readers of non-gated studies can visually estimate CAC on these scans, classifying patients into general CAC score groups to correlate accurately with traditional Agatston score groups. As Dr. Blaha mentioned, in 2018, the SCCT published the Coronary Artery Calcium Data and Reporting System. This is a unique approach to reporting CAC, which aims to standardize the methodology for reporting findings about CAC on all gated cardiac scans and non-gated chest CT scans. The CAC DRS, which is a shortcut for Coronary Artery Calcium Data and Reporting System, the CAC DRS categories of 0 to 3 were defined to correspond with the traditional Agatston categories of 0, which is low, 1 to 99, mild, 100 to 299, which is moderate, and above 300, which is moderate to severely increased risk. Visual assessment of CAC on non-gated scans is done with these same categories in mind, with scores from 0 to 3 corresponding to similar categories. Work has also been done on automating CAC scoring on thoracic scans. And although the CAC scores were underestimated, initial testing showed good reliability and agreement with traditional scores. If further developed, this holds significant potential for further reducing the time required to assess CAC on thoracic scans, increasing the efficiency and maximizing the value from routine lung cancer screening thoracic scans. So to summarize this, CAC should be reported on all chest CTs, and the CAC DRS system should be considered for use when interpreting non-gated chest CTs.
These are excellent points, guys. And for most stubborn imagers, me included, it's often difficult to change the current practice that we have from, say, not reporting either qualitative coronary calcium, or at least estimating, to reporting that routinely in all thoracic CT imaging that's performed at an institution. Great points. Before we conclude, are there any final comments about the review or about the CAC consortium in general that you'd like to make?
Yeah, thanks. I just appreciate the opportunity to have this podcast for the listeners. Yeah, I'll just say I think that the CAC consortium has been a very important effort for, number one, showing again how important it is to conduct clinical research and leverage existing medical records, existing patient experiences to achieve answers without having to necessarily in all cases do an expensive prospective cohort study. That's message number one. This could be replicated with many other radiology tests, not just the calcium score, with some of the same methods. Number two, the calcium consortium has been extremely important at confirming what we have in our guidelines, but then also moving forward. we didn't get a chance to even talk as much about calcium scoring in young individuals, which the Calcium Consortium has offered some new data, including some data even down to 20 and 30-year-olds, where about 1 in 10 patients can have even minimal calcification identified very early in life. The median score of 4 in the people with calcium in the 20 to 30-year-olds, indicating that I think the calcium score is going to be moving towards younger age groups in the future, at least in higher risk subgroups, because you can detect calcium at its earliest stages. You can really start treatment earlier. And we all know that starting treatment earlier makes sense, but you just can't treat everyone. So I think that's another area where the calcium score is going to push the limits of what's currently accepted and for select imaging, for example, of younger individuals, but also older individuals where you can find 1 in 5 adults above the age of 75 who've got a score of 0. So I think the calcium score is also pushed beyond current guidelines. And I think you're going to see that, for example, in the future guidelines, the National Lipid Association, which should be out soon, that will endorse a little bit more broad thinking about calcium scoring rather than what's just in the ACC AHA guidelines. And I think they're going to point to the Calcium Consortium a lot in those NLA guidelines. So this review that we've put together here, I think summarizes a lot of what we've learned from the consortium. I think will be a good reference for anyone who wants to think about where the future is with the Calcium Consortium. And Omar, I think you want to make maybe 1 or 2 remarks about where we're headed with the consortium, for example, extending the follow-up.
Yeah, so first of all, thank you so much actually for the opportunity to have this podcast today. And I would like to say also, first and foremost, this is all teamwork. And I would like to point out also some of the co-investigators in the CAC consortium, namely Dr. Berman, Dr. Budov, Dr. Midema, Dr. Nasir, Dr. Rosansky, Dr. Ramberger, Dr. Shaw. Without their help, actually, this wouldn't be possible. And some final words from my side also about the CAC consortium. So the CAC consortium strengthens the argument for a more extensive use of CAC in clinical practice. Based on the largest CAC scoring cohort yet assembled, CAC has shown to be a consistent and reliable predictor of all-cause, CHD, CVD, and even non-CVD mortality across subgroups based on sex, race, and patient groups at all traditional cardiovascular risk levels. CAC offers more than advice on treatment recommendations. As Dr. Blaha mentioned, as a negative risk factor, CAC 0 de-risks patients and gives certainty regarding favorable all-cause prognosis. So this concept of the power of 0, which Dr. Nasir quite often mentions, has been referred to repeatedly over the past years, implying the tremendous benefits gained from such score assuring both doctor and patient that no benefit from studies would be delivered. On the other hand, and Dr. Blaha is working on this concept now, and we have had the JACC imaging paper and another paper coming out soon in circulation about patients with a very high CAC score of above 1,000 should be considered a distinct patient subgroup that benefit from early and aggressive pharmacotherapy and possibly other therapeutic interventions. Last but not least, I think we do have actually great opportunities and possibilities still also in the CAC consortium in our follow-up studies. And as Dr. Blaha mentioned, we think we are considering right now to extend actually our follow-up. We are considering to pursue more studies, especially with extra coronary artery calcification. And then last but not least, it would be also interesting to think about possibilities to actually really extend also our cohorts to include more cohorts in the CAC consortium. Thank you.
Excellent. Excellent. Dr. Dize, Dr. Blaha, thank you guys so much. This conversation has been wonderful. I really appreciate your time and your expertise, and thank you for contributing your review of the CAC consortium results to the journal.
Thanks so much for having us on.
Thank you.
Of course. And to our listeners out there, I strongly, strongly encourage you to get your hands on this review that breaks down the CAC consortium results. This review is published in the Radiology Cardiothoracic Imaging Journal. Once again, my name is Praveen Ranganath, and if you like what you hear from us on the podcast, please rate, review, and subscribe to us. We will see you next time.